So I'm going to talk about orbital atherectomy for CTOs. No disclosures. So we know that atherectomy for CTOs is basically utilized in two settings, similar to the way you do for non-CTO PCI. You have the balloon uncrossable and the balloon undilatable lesions. The combined incidence in the CTO literature is anywhere from 6 to 12%. I think every year Manus kind of updates this. The latest numbers are 12%. And the use of atherectomy is safe in a variety of settings. So there are case reports, there are case series, and actually some larger case series that have looked at laser atherectomy and they've looked at rotational atherectomy. However, not much about orbital atherectomy out there. This is taken from Manus's excellent book and his lectures. These are just two algorithms within algorithms. So this is a term that Bill Lombardi uses. So you have the hybrid algorithm, but for everything that you do or you don't do or you can't do, there should be another algorithm. So the one on the right is the balloon uncrossable CTO algorithm. The one on the left is the balloon undilatable. And you can see that the atherectomy is there for both of them. It is not first line, however. So one thing to realize is that typically we're taught not to atherectomize after using balloon angioplasty. Typically this is done when balloons have been used. But again, there's very limited experience with orbital atherectomy, which is why I suspect it's not listed on either of these two charts. Okay, so the first case, so when do you use it? So I'm going to show you two cases where we almost had to use it, and this shows you the spectrum of what can go right and what can go wrong with this. Okay, so 75-year-old man with progressive exertional dyspnea, ejection fraction 45% with apical hyperkinesis, moderate anterior wall and anterolateral ischemia. This is a dual sort of angiogram. You can see that this is a long CTO of the LAD, and there perhaps maybe two CTOs. I'll let that run one more time. There's a retrograde collateral from that PDA is thin, supplies about an inch in the midsegment, but is diseased. And then there's a much larger epicardial collateral here. So in terms of scoring this, JCTO score of 3, progress CTO score of 2. The cap is somewhat ambiguous. There's a high-grade stenosis just proximal to it. The target is well defined, however, the lesion length is long, and there's a second CTO in there. And so we decided that we would try with an antegrade wire escalation strategy. If that failed, we'd try antegrade dissection reentry, and if not, we'd bring him back and try epicardial. So going ahead, so this is the first. So first of all, we had challenges just getting into that cap, and so we ended up using a turnpike spiral and a samurai wire. Samurai is Boston's version of Scion. We got into that septal, got the catheter out there, then pulled the wire out, redirected the catheter. Then we used a fighter wire. That's Boston's version of the Fielder XT. It has a .008 tip. Got that into the cap, and I said we're making good progress. But here you can see now that the catheter is starting to buckle a bit. So this spiral catheter is somewhat bulkier than the LP, and you can see where the grooves are, the spiral, they're biting into the tissue. It's buckling a bit. I said, okay, well that's not working. So we advanced the wire and then changed out for a turnpike LP, and it made somewhat progress and not a whole lot. And again, as we were talking, sometimes we keep twisting these catheters, start to stick, and that's the first sign that the tip may be getting frayed. At that time, we needed more support. So here we've got a guide liner now. By this time, the guide is also a little softer. So we couldn't get the turnpike in there, so I said, well, let's see, we need something a little bit more robust. We don't have tornus, we let that go. So this is turnpike gold. And that, I just wanted to show this. I don't recommend spinning the gold this much. You can only spin it in one direction, but that's how much force is on the tip of that gold catheter. It's just not working. There are other options. For example, could we have done this with, an anchor technique? We thought about that. With the guide liner, it's very hard to get a second piece of equipment down there. We had 7 French system. But we took the turnpike out, the tip was frayed, so we took a new turnpike and confirmed that actually we had made some progress. So this balloon uncrossable lesion is now a balloon, we've gone to the second CTO. God, time is almost out. Okay, so we tried a Astaro 20, we tried a Confianza, I couldn't cross with that, tried an Astaro, I'm going to talk faster now. Finally got the Hornet to go in, did not want to work over the Hornet, so I said, let me try getting more balloons. That did not work, did BAM, try to get stuff down there, but try to BAM with the 1.5. Actually, here at the tip of that catheter actually is a balloon fragment from that previous BAM. I just did not feel comfortable working over the Hornet or pushing it forward because we were right at the collateral. As the last-ditch effort, what we decided to do was take the wire out and put in a Viper wire with a CTO bend on it. And we got that through that little channel that the Hornet had made, got it across. And here you can see then we changed out, we did our atherectomy. This is post-atherectomy results. This is angioplasty stenting. This is what the final looks like. So again, this was a true uncrossable lesion, and ultimately we had to just push the Viper through with a CTO bend. Okay, this might go quicker. It's CTO, a woman who has an RCA occlusion. She has a stent on the right side, on the left side, the flush occlusion of the ostium. We decided to go retrograde first. And this is one of those cases we had yesterday. Those of you in the session yesterday, we had a live case like this where the septals look pretty decent, but they're not very good. And you can try multiple septals, and you get hung up on tortuosity. We tried multiple wires. In fact, the only good collateral that I see is that second septal, and that's a retrograde takeoff behind a stent strut. So rather than mess with that, we said, you know what, we'll just try the anterior dissection reentry strategy. I changed out my guide to AL guide, Turnpike LP, and here's a Confianza Pro 12. I've scratched, I've made my little subintimal plane. And so a wire that I like for tracking is the Raider. So this is like a Pilot 200, maybe more support Pilot 400, think of it like that, with a longer ribbon at the tip. I like it for knuckling because what you can do is you can make a knuckle and you can twist the wire to tighten up the knuckle if it doesn't tighten up for you. Push it and you can untwist it. So you can't do that with any of the other wires. You can see we've gotten across, we've re-entered distally, the picture to confirm. Went ahead and we got a 1.0 balloon, and again we tried to get the 1.0 balloon across that mid portion, and I just can't seem to do it. We did BAM there, that did not work. We tried a 2.0 balloon, that did not work. So once again we said, well, it worked for us a few weeks ago, let's do the same thing. Same thing, we took the Viper, took the Raider out and got the CTO curve, got the Viper across and went across, looks really good. We used CSI, we used a glide assist for the proximal segment. And here's a live thing, and I just want to show the good, excellent technique I was using. They said, you go too fast. I said, okay, I'll slow down. You slowly advance it. And what happens is that the thing gets jammed in there and just stalls. So this whole thing, it cuts both ways. It does really cut deep both ways. It does not come out. So the thing was jammed. So to actually get it out, I had to pull on the wire and the device, and everything came out, so, which was kind of sort of tragic. But I said, okay, let me go ahead and rewire this. And I've rewired it, and what you may notice is that the wire trajectory is slightly different now. It's not hugging the calcium like it once was, and we took a picture, and there you see this perforation. So that's the other aspect of it. Okay, so I said, what do you do? I said, well, first of all, let's not anticoagulate. Get ready to harvest some fat. Phone a friend, and I called Bill Lombardi. This was my first fat embolization. I said, hey, Bill, this is what's going on. He said, yes, this is what you need to do. If the fat embolization doesn't work, you can inject thrombin, but you just give protamine and take everything out. Don't wait. And I said, well, I'm not really sure about that distal flow. And actually, before I called Bill, what I had done in the meantime is I put a balloon up. This is the first strategy, is you have to put a balloon up to stop the bleeding. And this is just a 2.0 balloon at very gentle pressure, so clearly we have the channel there. The problem with that, however, is that it secures the ongoing channel. So I said, I'm still not really sure about this fat embolization. I'm doing this for the first time. I said, let me make sure that I still have wire access. So we took a twin pass catheter, put a second wire down, put the microcatheter, a fine cross over the second wire, and used that to embolize fat. So we still had secure wire across into the true lumen. And what ended up happening is we did not get hemostasis, but we got ST elevation. So part of that fat actually went down. So we actually have antegrade flow, and I really don't want to, I guess I don't know what to do. So at that point, the thrombin idea sounded good. I just did not want to inject thrombin down the RCA, so we basically put a microcatheter, put a fine cross into the actual hematoma. We did an echo by this point and confirmed that this was in the wall of the right ventricle and not true pericardial effusion. And then we basically put a balloon up proximally, balloon occlusion proximally. This is the microcatheter in the little hematoma, and injected some thrombin out there. And then afterwards, we took everything out. And this is just our final angiography about 10-15 minutes later, and you can see the flow has actually stopped. And she actually did well. She was a little shook up, but she called to say that she felt better. So as an investment, this worked perfectly. As a case, it's not so glamorous or elegant, but now she wants to come back and have the thing taken care of permanently. Okay, so what have I learned about orbital atherectomy within the past year? This is the lessons. Number one, orbital atherectomy is a double-edged sword that should be used with caution. It's not a matter of being a good technology or a bad technology. It is what it is. It does its job. It's a matter of appropriate use. So what is appropriate use? It's best suited for balloon uncrossable and undilatable occlusions, which are relatively straight. What's the angle? I don't know, 45 degrees or less maybe. And the wire is intraluminal. That's where it works best. probably should not be used in subintimal areas, especially if the subintimal plane is going across an angle. And finally, balloon predilatation is not a contraindication to the use of orbital atherectomy. And in fact, I think many times, more often than not, we end up using balloons, failing, and then using one of these devices. Thank you.
Thank you, Sal, for showing this case. It's really, one time I actually sent a text, or I can't remember, it was a tweet. Would you use orbital atherectomy in a subintimal space? And the answer from Aaron Grantham said, I would not wobble in a subintimal space. It's just like one sentence.
And now we know why.
Exactly. Any questions? We actually, although you took longer time, but that's a great learning points. Anybody has any comments?
Should we conclude from this that we should not probably use orbital atherectomy in CTOS period? Because you can never be 100% sure that your wire went through and through all the way in the true lumen. So many times you need a section plane and back in a true lumen distance.
I think that's a fantastic point. So again, both of these situations were where I actually wasn't able to get any equipment across, and there was a last ditch thing where we took the wire out. So one thing is, should we be taking out the wire once we've crossed a CTO? That's one thing. But I'll tell you, so we had a similar case, and the reason I don't think we need to do this anymore is, CSI has, we don't have threader, we don't have glider, but they have a new balloon called Sapphire, and it's a 1 millimeter balloon, and that worked fantastic. I mean, so I had another situation where I really couldn't get any balloons down. I tried the 1520, we BAMmed it twice. We BAMmed the 1.25 from Abbott, that balloon didn't work, and those typically, get in deep into that. But that Sapphire seemed to do the trick. Now, it may be that the other balloons had softened it, but the point is, once we had the Sapphire, we could then change out for the Turnpike LP and put different wire, in which case we could use the Rhoda in this situation.
In fact, I asked the Vascular Solution, which is marketing, not Vascular Solution, CSI, which marketing it for Orbis niche, I think, to make it over the wire. Because what I had experience with the Sapphire 1 millimeter balloon, it will actually go, it's an RX, you dilate the lesion, and you come back with your microcatheter, still would not go. So you come back with the Sapphire, now winged, it will go. You come back with a 1.5 balloon like Emerge or Trek or something, and still wouldn't go. So I think that's the only balloon I might use over the wire. Otherwise, no use for over the wire balloons.
This is a really illustrative case. When you injected thrombin, did you have a distal balloon up to prevent reflux down the right coronary?
Exactly.
So I actually didn't know where to position that balloon. I didn't want to position over it because my feeling was if I position it right over there, it might expand that hole and that calcium might be pulled apart some more. But what we did was, and it doesn't show you in this, is actually we injected from the retrograde. So once we recreated that CTO, there was flow going in this direction. And it was just a drop of thrombin, but we took everything out. And then we put the balloon down to restore flow that way. But the answer is no, not distal to it, though we thought about that. That would have been the best way to do it.
I think that would have been great, like to put a balloon distal, balloon proximal, and a microcatheter in the middle, and put an, or actually just go ahead and put a covered stent. Like if you put a covered stent, committed, it's going to occlude, but you're going to come back and open at both ends and you're done.
He probably would have had to really definitively treat it with Rhoda and expand that whole plane of
so
Rhoda.
that was I gave him the covered stent, and let's just say that in our cath lab these things get scrutinized, and as it is, I'm trying to get the CTO program going.
Not a great case for scrutiny.
One covered stent, one covered stent per month. That's it.